Hi, my name is Albert Chiou. I'm a medical dermatologist over at Stanford. I serve as director for clinical research for our department and have been involved in a number of clinical trials in atopic dermatitis. And I'm excited to talk to you about one set of results from those today. Yeah, we're sharing the final results from our phase one randomized placebo-controlled and blinded trial looking at the effects of soquelitinib in moderate to severe atopic dermatitis. So in general, we saw some very encouraging results. We observed an early and deep response in skin clearance for patients who were treated with soquelitinib, even with just 4 to 8 weeks of treatment at the tested doses. We were able to share some interesting newer data, including the fact that patients treated with the highest tested dose, even for just 4 weeks, experienced durability in their clinical improvement for up to 90 days after the last dose of treatment. And finally, we presented the recently completed cohort 4 data, where patients underwent the longest treatment duration of 8 weeks. And these patients showed continued clinical improvement up until the last day of treatment without any plateau in their clinical response within the treatment period. So that's really exciting from the trialist perspective. Yeah, so we were really excited to see this result, especially for our patients and for our field. We're seeing an oral medication that potentially has a clean safety profile that can provide patients with sustained relief for potentially up to 90 days or longer. And keep in mind the durability that we saw in our trial actually extended all the way to the last day of follow-up. So it could actually persist longer. It's just that's how far out that follow-up was designed for. So this could potentially change how we treat our patients with atopic dermatitis, as a lot of our current paradigms typically involve ongoing therapy, whether with a biologic or an oral medication. And we know that in many cases for folks with moderate to severe disease, if you stop that medication, there's a pretty good chance that that skin disease is going to come back, and patients oftentimes flare and need rescue medications. So, with this type of remittive effect that we're seeing, you could imagine a world where you treat for short periods of time, allow patients to experience significant periods off therapy, and then repeat as needed to maintain control. So, in general, I think if I were a patient with AD, this sounds like this would be a pretty fantastic place to be in terms of a therapy. So ITK stands for interleukin-2 inducible T cell kinase, and it's a target expressed in T, NK, and ILC2 cells. So actually a fairly narrow distribution of where this target is expressed. And it promotes the differentiation of naive T cells into Th2 and Th17 cells. So when you block this, you actually have potent inhibition of Th2 and the atopic dermatitis related cytokines. So that's the rationale for its use in AD here. And importantly, it also promotes a shift from Th17 inflammation to T regulatory cells. So the Tregs are brakes on our inflammatory response. And so we think that that's a plausible mechanistic explanation for the durability that we see in the trial. So my colleague, Dr. Kavita Sarin, actually presented some great data here where they saw that patients tested with the highest dose of soquelitinib on this trial. We actually saw an increase in T regulatory cells in the blood that actually persisted even once the medication completed its last dose. So this target and this medication, it's different than the JAKs. One, there's that tissue selectivity on where the target is expressed, and it doesn't target the JAK-STAT pathway directly. Because soquelitinib actually spares another critical tech family kinase called RLK, in terms of its mechanism, it should spare Th1 immunity. So this is not a broad immunosuppressive effect. And so we expect to see benefits in terms of safety from how this pathway works. And so compared to dupilumab, again, we're not focused now on cytokines, but rather T cell differentiation. So we're working upstream of that target.